histopathology or cytology knows her very well. She is Director of Surgical Pathology, NM Diagnostics at Jaslok Hospital, Mumbai. And she is having experience of long 43 years. And she was faculty at Tata Memorial Hospital for 35 years and retired as head of the Department of Pathology from Tata. She is having almost 270 scientific articles in reputed international journals with two publications in New England Journal of Medicine. And she is having 15 chapters in different books on gynec cancer, exfoliative cytology, FNAC, and head and neck cancers. She delivered more than 500 talks, orations, and lectures at different conferences. She is having different researches on her name, and she took training in oncopathology in various institutes of USA, and she is having a special interest in head and neck cancer and gynec cytology and FNAC. So welcome, madam.
So good evening, everybody. We really wish you happy Gudi Padwa to all, which is the New Year day for us. And I'm really happy to join this Kaho community on this auspicious day and to talk on pleural fluid cytology because I have a passion for teaching both cytology as well as the histology topics. So I would like to thank organizers for giving me this opportunity. Since Manjeet, and let's start straight with the quiz. So what are the challenges in pleural fluid cytology? Is first to detect the malignant cells and distinguish it from reactive mesothelial cells. I'm not going to dwell in that because this is a perpetual dilemma for every cytologist who is reporting on any fluid cytology. Now, sometimes it is very easy to say that there are some atypical or rather malignant cells in the fluid, but it is difficult to classify that malignancy. And we will see some of the examples. In other times, in a no-treated case of malignancy, see malignant cells, they may be carcinoma cells, but you feel that the histomorphology, cytomorphology of this cell doesn't match the histomorphology, what we expect of the primary. And then it is a challenging. Rarely you may come across unknown primary malignancy, means the pleural fluid is the first presentation of that malignancy. So you don't have a background of what was the primary, what was the surgery, how it was treated, etc. And then not only you have to diagnose in absence of any primary, but you have to classify that malignancy. And anything and everything can come in this, though carcinoma will be more common. You have seen there are host of other tumors which can also rarely present as a primary. And the reasons are very many. Again, we'll come to it later. Then lymphocyte-rich fluids. Then the difficult challenge is that whether it is really a lymphoma or reactive lymphocytic effusion. And when you see cells like mesothelial, again, it is a reactive mesothelial proliferation or malignant mesothelioma. So challenges are many. So what we have to learn now is how to go about and how to solve these diagnostic dilemmas or challenges. So let's start with the first case, which is a 55-year-old female, a very active housewife, who presented with sudden cough and breathlessness and was taken to casualty section on a Sunday night. So she didn't have any previous history of any medical disease or surgery or any illness for that matter, but she had a history of trauma a few days ago. And on examination, right pleural effusion was noted, which was 500 ml of hemorrhagic fluid was tapped. The abdomen though was very clear and there was no ascites and no mass anywhere. So this is what the appearance was, cellular, hemorrhagic background, and the clusters of cells, which is a common appearance in fluid. You have, Dr. Manjeet has shown you all the different patterns. So this is not just the clusters, but rather papillary clusters, as you can see. These are all real cases, real problematic cases, not downloaded from net. So cellular smears with papillary clusters, more or less monotonous. When I say monotonous means the cell type is one. Within the cluster, you will see pleomorphism, nuclear pleomorphism, and these cells appear naturally epithelial, which are atypical. So with this, it is very easy to say that most probably this is a case of a metastatic adenocarcinoma. So as I said, sometimes diagnosis of what the malignant cell belong to may be easy. Okay. And in this case, there are not many benign mesothelial cells. As she said, sometimes you get, background full of mesothelial cells and histiocytes, but sometimes backgrounds may be clear and there may be only blood, as we saw in this case. Now, here the challenge was, where are these cells coming from? So this is a cell block. So let's see, are there any clues? So papillary clusters, okay, glandular. So basically, adenocarcinoma, pleomorphic cells. Some of them are showing vacuolated cytoplasm, but they don't appear signet ring cell, because once you say signet ring cells, it narrows down to GI tract and very rarely mesothelioma, which can also show you signet ring cells. But these are basically vacuolated cytoplasm, pleomorphic nuclei, as you can see here, and the important clue is polyploidal cells. Can any one of you say what this could be? What this stands for? Papillary, vacuolated, and lack of mucin, and a polyploidal. Sorry for that mistake. So what was the differential? Papillary mesothelioma, because there was no primary. Mesothelioma also presents as a papillary clusters. Schwannoma bodies were not seen. But mind you, rarely mesothelioma can also show Schwannoma bodies. We have seen cases. And then metastasis of papillary adenocarcinoma. And can be the likely primary site? First of all, in females, ovary and breast. But when you are dealing with pleural effusion, breast comes first and then ovary in the and primarily seen in ascitic fluid. Also, lung adenocarcinoma, where females are more commonly affected than males, and pancreaticobiliary, where males are more commonly affected. So, if it is a pleural effusion, you think of breast and lung. If it is ascitic, females, ovaries, males may see pancreaticobiliary. But remember, you can also see these in the females. There are some other rare tumors which can also show papillary pattern like RCC, PCC, papillary thyroid carcinoma, but effusion is very rare. So you don't consider primary. So what happened in this case? We could give the report of metastasis of papillary adenocarcinoma to look for primary in the breast and lung and await immunohistochemistry. So meanwhile, we wanted clinicians to have a look whether any one of these organs were involved. Now, how do you decide which immunohistochemistry markers to put when you do not have any idea of what is the primary? So these are the markers. All of you know about it. Now, initially, you put one marker for each side. So GATA3, TTF1, you can put PAC-SET for ovary, CK19. Most of us do not have SMAD4, which is lost in pancreaticobiliary tree. And for mesothelioma, calretinine, WT1 also, and D240. So you will select one marker from each and you will make a primary panel. So my idea was to tell you what is the diagnostic algorithm. Having known what is the cytomorphology for each organ and what is the spectrum. So now in this case, surgeon could not detect any primary. There was not any suggestion of the primary. So we use calretinine, PAC-SET, TTF1, and GATA3. Can you suggest which one must have come positive? Now, depending upon the positivity in the primary panel, we go and form the secondary panel. So in this case, instead of GATA3, PAC-SET came positive. Now, you know that PAC-SET comes positive in a variety of organs, but in this situation, the first organ, what we will think of is ovary. PAC-SET can come in thyroid, kidney, and even in thymic tumors. So we use the secondary panel of WT1 P53. We can also add P60 to see whether it is ovary or not. And this is how the cell block clearly gave the mandate of ovary. CK7, this is not CK7, it is moved from here. I think I have to take it down. This is PAC-SET, WT1, and P53. Luckily for ovary, these three are nuclear markers, and this one is cytoplasmic. Okay. So you must have one nuclear marker and one cytoplasm. It gives you a good balance. So all came beautifully positive because it was a papillary serous carcinoma. Okay, Shamoma bodies were not seen. But this could have been any other primary also. Though, because it was a female, we would just think of ovary first for this particular cytomorphology. We have to use other markers also. Now, did it solve our problem? Many of you must have diagnosed based on cytomorphology, even though Shamoma bodies were not there, serous type of or papillary serous carcinoma. So what are the likely primary sites? First, of course, is ovary, then fallopian tube, uterus, cervix, and pelvic peritoneum. All these also can show primary serous papillary carcinoma. However, here abdominal USG was negative, so also there was no ascitic fluid, and this was the challenge. Then how do you treat without knowing primary? How do you treat? So now these days everything is discussed in the tumor board meeting. This is actually an old case, but Tata Hospital always had tumor board meetings. And then the decision was taken to treat this case as a CA ovary, even though ovaries look normal on radiology. So 4 cycles of chemotherapy were given for ovary. This was followed by TAH and salpingo-oophorectomy. Omentectomy was also done like a standard procedure for CA ovary. Bilateral ovaries and tubes were normal in size on gross. Omentum was also normal on gross. So till we saw the microscopic section, we did not know what was the primary. And there in right ovary, there was a very small primary focus 2 millimeter, which was a residual inviable just below the surface, and all other organs were free. Because you know, in the serous carcinoma can spread to other organs as well. So now this was an occult ovarian primary with rare presentation with pleural effusion. This case was actually known to me, and this case was registered at Hinduja Hospital. And because this patient was known to me, I was involved very much in this particular case. The challenge here was not really identifying what could be the primary, but to take a decision that yes, is the ovary which must be the primary, and to go ahead with the treatment. Now, occult primaries are known in adenocarcinoma as well as a squamous carcinoma. The common primaries are, of course, lung, pancreas, breast, and prostate. So pathologists and clinicians are geared to detect these primaries in the fluids, and these three can, of course, present in the pleural or ascitic fluid. But ovary hardly ever presents. So here the presentation works little different. So with that, we go to case 2. At the end, I can take any questions. So this was a 42-year male, a physical trainer, a very strong body, who presented with left-sided pleural effusion, which was slowly filling and breathlessness. Unlike the primary case, it was rapidly filling pleural effusion. Again, here also, there was the unknown primary. Now, all these unknown primaries are of different types. And at the end, of course, I will discuss. The first case was really unknown primary and it was occult or clinically not apparent even after investigation. Now that was showing cohesive tight cluster, and see here how is the cell spread. It is all dissociated or singly occurring or non-cohesive, and they are much larger than previous. They are much more monotonous in this particular field. And what you can notice is the presence of prominent nucleoli with good amount of cytoplasm. But cytoplasm doesn't show any mucin or anything else. So, okay, you go further. So, where the clusters were seen. Even in fluid, the appearance may not be same in every field. You can get combination of cluster as well as dissociated cells. And the size also can vary. Now, clusters usually the size appears small. Then there were intermediate size and there were some large size, hyperchromatic nuclei, as you can see here. Now, can you make out anything more here? This is little, I think this is 100x, so that's why the appearance. So you look here, there are multinucleated cells. This is not binucleated. There are two cells. The nuclei are almost kissing each other. Look here, what we can see here is is clearly, what do you call this? Phagocytosis, cannibalism. So multinucleation, cannibalism, abundant cytoplasm. So this can be all seen in mesothelial cells. So how many of you think it to be a mesothelial cells? No primary, large cells, dissociated cells. As Manjeet has already told you, mesothelial cells can come in papillary clusters as well as dissociated, usually quite large because small cell mesothelioma is very rare. So usually the mesothelial cells appear large. Then sometimes even a stomach poorly cohesive carcinoma can appear like this. Okay, large cell, dissociated cell, round nuclei, and sometimes prominent nucleoli. So is it carcinoma or is it mesothelioma? What do you think? If it is adenocarcinoma, where is the primary? Okay. So however much we do not like to sit on friends, pathologists do have to do and clinicians get it, we know. So in this case, pleural fluid cell block report these few scattered clusters of large atypical cells with prominent nucleoli along with dissociated cells on hemorrhagic background, suggestive of polydifferentiated adenocarcinoma. So this is the point I wanted to make. Whenever in fluid, you get clusters, you get large or epithelial looking cells, our first diagnosis, without thinking, we say it is polydifferentiated adenocarcinoma. And that's what happened. And whether primary is known or not known, even in unknown primary, most common will be adenocarcinoma, isn't it? So we went on doing wide panel of immunohistochemistry markers like CK7, CK20, TTF1, and napsin for lung. And this was a male patient, so we didn't think of a breast. Calretinine, WT1 for mesothelioma. CK56 also for mesothelioma, rarely squamous carcinoma, though here we did not suspect. But all were negative. What does it signify? Can we really rule out carcinoma? So what we said, we want to do additional immunohistochemistry. So we told clinicians to re-evaluate and let us know the primary if they have found so far. So we said, let's review our own slide and see whether any more diagnostic clues. So no wonder they were very prominent nucleoli, as you can clearly see here, though all cells did not show. Basically, the large cells showed prominent nucleoli, and the cells appeared a bit plasmacytoid at places. But you have to carefully use the word plasmacytoid cells, They can be seen in variety of malignancies like adenocarcinoma, neuroendocrine carcinoma. Large cell neuroendocrine carcinoma can also show large cells with eccentric nuclei, melanoma, myoepithelial neoplasm, plasmablastic lymphoma, and of course plasmacytoma. So with this background, can you guess what it could be? It shows prominent nucleoli, it shows cannibalism, it shows plasmacytoid cells, but on closer looking, it also showed binucleate cells, but this is not giving us much clue. We saw intranuclear cytoplasmic inclusion. And this made us feel or think that this is not going to be carcinoma, but it is likely to be melanoma. So on further search, we got only one cell here in this stain smear showing this melanin pigment in the cytoplasm. Okay. Again, this is 100x, the oil immersion, just to show you the pigment in the cytoplasm. All the rest of the cell, there is no, idea that these cells are having pigment. Now, I have observed sometimes that you may not see granules like this, but the cytoplasm gets a different tinge when you have a less pigment. We clearly see the pigment when the pigment is abundant, but otherwise the cytoplasm shows a tinge. And you really have to pick up. You really need the observing eye for that. And this was MJG stain where the pigment deposition you appreciate much more. Okay. So this was clearly a case of malignant melanoma where most of the cells were amelanotic. And then we also confirmed with immunohistochemistry. Once you see the pigment, I don't think we really need to, confirm. This is S100 positive in nuclei as well as cytoplasm and HMB45, which is a cytoplasmic positivity. So ICC here was done on limited smear. Mind you, every time you do not get the cell block, these days many laboratories routinely make a cell block, so they always have that backup. But previously, every pleural fluid cell block was not made. And then when we asked him closely what was the history, the clinician couldn't provide us history, funnily, but patient gave the history that he had ulcerative lesion on the great toe, which is a classical site, and that was operated outside, and that was reported as melanoma. And this is later on we did cell block, and HMB45 is nicely positive on this. So this was a case of a metastatic amelanotic melanoma with primary in right great toe, excised outside. So here, this was not an unknown primary, it was a forgotten primary. And this tells you the importance of a detailed history checking. At no stage, at today also, after 40 years of working in this, I have to call the patient and get history personally, only to, only to track all these challenging cases. We cannot always depend on the clinicians for taking history. So now melanoma we see of cutaneous origin as well as the mucosal melanoma. But it is the cutaneous origin which develops serous effusions, not mucosal melanoma. So while asking history also, you have to be particular and asking the cutaneous region. I distinctly remember that first year joining that hospital, I got a pleural effusion and I saw the cells. But there it wasn't amelanotic melanoma. Some of them did show clear pigment. So my diagnosis was metastatic melanoma. And when I saw the chart, there was no history of any surgery, nothing. When I called the patient, and this patient was a bhaiya, Hindi speaking bhaiya from North India. Okay. So when I asked him just any operation, then he said, yes, I underwent inguinal node surgery, of course, in whatever language he spoke. And that then what was the histology report? That was not saying for histology. Then I just asked, तुम्हारे चमड़ी पे कुछ काला धब्बा था क्या? I'm just telling you, how important. And he immediately came out. He had kala dhabba on the sole of foot, which was excised, again, which was not sent for histopathological examination. These are, of course, old cases I said when at the time of joining that hospital. Then 2 years later, he had a inguinal node. I'm sorry, that was sent for histopathology. That was reported as spindle cell sarcoma because that was spindly melanoma. And again, that didn't show the pigment. And 2 years down the line, he presented with pleural effusion, and that time he was referred to Tata Hospital. Naturally, being tertiary cancer referral center, quite often we got terminal cases or widely metastatic. And then when I told clinician this is melanoma, clinician was very much, surprised. How come it is melanoma? Patient doesn't have anything on the skin or he didn't give history. Then I had to tell him that I have dug up the history of this and patient had a pigmented patch on the skin, but it was not subjected to histopathology. So this I am telling you just to emphasize how important the history is. In pathology, you cannot, just report metastatic melanoma. And that time, I think immunohistochemistry also wasn't there. Just because I see, sorry, just because I see, anybody is asking me or I am not hearing that properly. So just because I see pigmented cells jumping to melanoma is not wise, and that's why I had to get the history from the patient. So serous effusion may be the first manifestation of metastatic melanoma several years down the line after the treatment of primary neoplasm. So melanomas also can be occult, but by the time it gets pleural effusion, it will also have involvement of some other organ, basically the nodes. So confirmation of diagnosis was aided by immunohistochemistry around melanoma HMB45 in this case, which were considered to be the gold standard for melanoma. But the case I discussed with you, we could not do immunohistochemistry. So keep in mind amelanotic melanoma when large epithelioid cells are seen. So the message here is when you see large epithelioid cell, whether with cluster, without cluster, with prominent nucleoli or not, please do not jump to the conclusion of metastatic carcinoma unless there is a known primary carcinoma. Then you don't have to think of melanoma. So absence of obvious melanin pigment and possible regression of primary melanotic lesion often pose diagnostic challenge. So in this case, it is a forgotten primary and not really an unknown primary. So you must know that eyes do not see what mind doesn't know. So that's why you have to keep wide option and a full spectrum of malignancy. So this takes us to the challenging case 3. The clinical details goes like 35 years old male who was a trainer, physical trainer. She must have. Anyway, presented with light pleural effusion, and this also did not have a primary. So as I said, I'm showing you all the different case scenarios of the primary. So again, dissociated cells and a few clusters. Okay. Now, all these were cellular, but cellularity doesn't give you the answer. On closer look, again, large cells, raised nuclear cytoplasmic ratio, and prominent nucleoli. Somewhat similar to previous sort of case. No pigment here, no mucin. So these are the things you always try to look for as additional clues, mainly dissociated, very few clusters. I have just highlighted the clusters here. Binucleated cells, multinucleated cells, and see the background cell. Now, all these are not tumor cells, quite a few are tumor, but in addition, you also see lymphocytes and histiocytes. Is it giving you any clue? So one by one, I'm adding the morphological features to make you think that what it could be. Young patient, large cells, mainly dissociated, non-cohesive, very few loose clusters. Again, clusters, tight cohesive or loose clusters are important. Tight cohesive, carcinoma. Loose cohesive may not be carcinoma. So again, the DDs were carcinoma, mesothelioma, or any other malignancy, even melanoma. Okay. Now see, some of these are actually lymphocytes in the background, and this is very important. Histiocytes were also seen, large cells, and some showing prominent nucleoli. So we have to go by by the frequency. So polydifferentiated carcinoma, amelanotic melanoma, mesothelioma, sarcoma with epithelioid features. Okay. Now what will you do? You cannot. Now, if you have the cell block, of course, you will do the immunohistochemistry. What immunohistochemistry you will do? CK or CK7, CK20 for carcinoma. S100 will be the board marker, sensitive, not specific. So when you select again the panel for the immunohistochemistry, select the more ubiquitous or more sensitive marker than specific. And depending on what sensitive marker comes positive, then you go on to do the specific marker to confirm the diagnosis. So CK7, CK20, S100 for mesothelia, calretinine, vimentin, etc. For sarcoma, you cannot really ask. But we prefer to dig out the history. And this patient had a very long history. Left scrotal orchidectomy 8 years ago. Dissection of a metastatic retroperitoneal node 6 years ago. So the current values also were done. Reports were awaited, but by the time we got the chart, the AFP and serum beta HCG were available. They were not markedly raised to suggest, germ cell tumor. PET scan was done. FDG avid bulky soft tissue mass was noted in the left lumbar lesion at the time of presentation. And this was quite big, 16.4 centimeter mass with maximum SUV was 12.92. So now it is very clear that this is a case of a germ cell tumor, but not necessarily non-seminomatous germ cell tumor because these two markers were normal. So in this case, history was hidden, primary was not hidden. So patient kept on getting, swellings and kept on being treated. And finally, he presented with this. But if you don't know the history of germ cell tumor or orchidectomy, it is very difficult to diagnose because it is extremely rare to get germ cell tumor in the effusion. So we'll only think of germ cell tumor in the young males when you see only dissociated large cells. Some of these are showing naked round nuclei. Some of them are showing prominent nucleoli, as you can see here. There are lymphocytes in the background. Then you may think of germ cell, but you have to get the history. So patients should present with the testicular tumor, or there has to be history of surgery for testicular tumor, radiotherapy and chemotherapy as well. So later on, we did, because the fluids are always preserved, cell block was done later on. And this was the immunohisto which was done on cell block, that is G240. This is c-kit. And our CD30 was negative. CD30 is done basically for embryonal carcinoma. Some of the markers are common, that is OCT34 and SAL4 will be seen in both seminoma and embryonal carcinoma. But c-kit and D240 for seminoma, and CD30 and CK for embryonal carcinoma. So here also I would like to say when you get CK positivity Don't again jump to the diagnosis of carcinoma. If patient is young, you keep in mind embryonal carcinoma as well and try to get the history. So here it was features consistent with fluid involvement with seminoma in a known case of testicular seminoma. Now, when you get a malignant pleural effusion in a testicular tumor, it is more commonly associated with non-seminomatous germ cell tumor, which are more like a epithelial tumors as compared to pure seminoma. You can get it in mixed testicular tumor also. So it is extremely rare to get pure seminoma in effusion. So that is why I'm trying to show you all different spectrum which you can see apart from carcinoma. Only the first case I showed because it was a typical case and a very common case, but here the primary was not known. So in these three cases, the fluid showed large epithelioid cells, somewhere with clusters, somewhere without clusters, and the cytomorphology was really matching with the histomorphology of primary lesion. But either the primary was not known, primary was forgotten in second case, and melanin pigment was not there, or in third case, the history was hidden. We did not know. So now we move on to case 457 female operated case of papillary thyroid carcinoma 2 years ago. So your history is clearly known. But does that mean diagnosis is written on the smear? No. She presented with right pleural effusion and also right cervical lymphadenopathy. So pleural tapping was done and cervical node FNC also was done. Histology of a total thyroidectomy was then reviewed. So when we got pleural field, of course, we did not know cervical node FNC was done because it goes to the two different sections in the laboratory. So this is from the pleural fluid cytology. Again, very large cell, raised nucleocytoplasmic ratio. Some clusters, some are loosely cohesive, some very large cells. Okay. So is it looking like papillary carcinoma? Not at all. The history given was papillary carcinoma. So here you have to think in two different ways. Is it some variant of papillary carcinoma which was in primary, was not detected? In somebody had just reported papillary carcinoma, or is it something else? So now how will you go about? Are you thinking of second primary? So as and when you get a challenging case, you have to think on the spot, you know. Now, this primary thyroid carcinoma, no differentiated carcinoma will show you cells like this, right? In the background, some cells look different, but they are part of this tumor only. These are also not papillary thyroid carcinoma. Okay. This is part of, and some cells are very large. This is multinucleated. This is sort of a binucleated with very irregular nuclei. Some polymorphs are also seen, which you usually see in this particular tumor. So are you getting closer to the diagnosis? Is it the same primary or is it the second primary? That also one has to think. Pap smear, large cell with bar multinucleation, lot of pleomorphic cells, somewhere like carcinoma-like cells were there, and somewhere anaplastic cells. So now this gives you the clue. Irregular nuclear membrane, coarse irregular chromatin clumping, macronucleoli with scattered plasmacytoid cells also, and multinucleated cells with lymphocyte polymorphs in the background. I did not see mitotic figure, but such kind of tumors usually show mitotic figure. In fact, these are, see, mind you, what pictures they are showing, they don't even represent one high power field, you know, they are very, so most of the things are not seen there. But in this particular case, you should look for mitosis and necrosis. And I'll come to it little later. So differential diagnosis, is it oncocytic carcinoma, that is Hurdle cell carcinoma? Is it oncocytic medullary thyroid carcinoma, which can show you multinucleated, binucleated cell? Is it second primary like lung adenocarcinoma? Is it squamous cell carcinoma? So a lot of questions went to our mind. Okay. But then we came to know there is a lymph node FNAC also. You know, as pathologists are more used to analyzing the FNAC. So look at this. This was also cellular. Okay. Varied kind of cells, dissociated and giant cells of different types. Here again, giant cell nucleus is showing intranuclear cytoplasmic inclusion, but no way you can consider it as a papillary carcinoma. So what is it? Any guess? I think now all of you must be certain what it is. Then again we ask clinician if there is any other primary. So clinician said no, no primary. only history, whatever we had is given. So we thought of whether to, confirm whether is it of thyroid origin. So we did FACSET, look at the small cell also. Small means intermediate size cells are also positive. This large cell is also positive with FACSET, and P53 is positive. I think this was done on pleural fluid and this was done on FNAC because this is matching with the FNAC. So this was FACSET P53 positive, TTF1, TG, and P40 was negative. If it was a papillary thyroid carcinoma, you should have expected TTF1 and TG to be positive, for squamous carcinoma, P40 positive. So this was in fact a case of anaplastic carcinoma of a thyroid. This was the final verdict. Originally, it was papillary thyroid carcinoma. It is possible that inadequate sampling has missed anaplastic carcinoma or there was no anaplastic carcinoma then, but usually anaplastic carcinoma takes a longer duration. Any dedifferentiation doesn't occur overnight. It takes many years. So we expect that the small focus of anaplastic carcinoma was missed. Okay. And therefore, it later on presented with pleural effusion. So the report went as metastatic anaplastic thyroid carcinoma arising from papillary thyroid carcinoma with lung node metastasis as well as pleural effusion. So message here is if cytology of a known primary does not match with that of effusion cytology, then think about either a special variant of primary. Say in papillary, you can expect columnar cell variant, tall cell, hobnail cell, which are aggressive and which can in fact go to pleural fluid. And we have seen cases of tall cell papillary thyroid carcinoma in pleural fluid, very rare cases. Or in this particular case, which obviously showed number of giant cells, it was a case of an anaplastic carcinoma. You should think of progression in the primary leading to dedifferentiation arising within the primary tumor, and in this case, it was papillary thyroid carcinoma. Similar situation can also be seen in salivary gland tumors, where low-grade salivary gland tumors, after a long duration, become a high-grade transformation in salivary, and then it can present the pleural fluid. So also we have high-grade carcinoma arising from pleomorphic adenoma, carcinoma ex pleomorphic adenoma, which can also then go to pleural fluid. So this is what the histology showed, metastasis of anaplastic carcinoma. So the diagnosis was then cleared because of the history. But imagine if we didn't have the history of papillary carcinoma, then how difficult it could have been. As mentioned earlier, this kind of appearance you can also get in case of a carcinoma pancreas. So depending upon whether it is ascitic fluid or this, you can distinguish the two. The next case was a 45 years female, a school teacher, who was treated for CA right breast, which was called infiltrating breast carcinoma, NS3 grade 2. 5 years ago, and a lumpectomy axillary node dissection was done. Nodes were negative, radiotherapy was given, and then she presented with left pleural effusion. Okay, later. When on examination, the clinician notes said her breast is normal, abdominal examination is normal. The radiology showed pleural deposits and lung mets. So no lesion was seen in the breast. And this is how the pleural fluid appeared. Loosely cohesive cluster, smaller cells, hardly any cytoplasm, as you can see, and then these are the background cells. So this is obviously small to intermediate size cells with a very rare nucleocytoplasmic ratio. Cellular smears, clusters, dissociated smaller cell, frankly malignant. You have no doubt that it is malignant and it is non-lymphal. So what is it? Is it small cell carcinoma lung? Small cell carcinoma goes to pleural fluid. By the way, it is again aggressive. So if you consider what are the aggressive malignancies overall in the body, small cell carcinoma, malignant melanoma, any anaplastic carcinoma are very aggressive and they can go to any place in the body. Renal cell carcinoma is not aggressive in morphology or otherwise, but that can also metastasize to any organ. Okay? So these were dissociated cell of varying size, some were small, some showed cytoplasm, and some were very large, as you can see here. So again, this was combination. So sometimes in pleural fluid, you have one type of cell, what we saw in the first case, that was papillary clusters, one type of cell, one type of pattern that is cohesive. Whereas sometimes combination, dissociated cells and the cluster. Still, they can be of one type or they can be of different sizes, as you can see here. And you have to note down everything because in the final stage, it is really every single morphological feature is important. And the collation of information, it is one thing to have the good observation, but it is other thing to have a good interpretation of that observation. So first stage is collect the data, and second stage will be collate the data. Again, plasmacytoid cells, is it really helpful? Yes and no. Sometimes it is helpful. So melanoma, plasmacytoid cells will be helpful. Plasmablastic lymphoma, of course. When the cells are smaller and plasmacytoid and from salivary gland, it is helpful. It is a myoepithelial, not so much in for the fluid. So these were distinctly plasmacytoid cells, but they were basically larger cells which were plasmacytoid. Background cells were not plasmacytoid. So we were stuck here because they didn't look like a breast carcinoma cells, where there was a history of breast carcinoma. So if you have history also, you can be in the trouble. If you don't have history also, you can be. So these were metastatic cells seen consistent with polydifferentiated carcinoma in a non-treated case. This is how our report went. So you have to issue report 2 days, 3 days for pleural fluid particularly and give the guidance to the clinician and discuss with them. That is very important. But they clearly, threw their hand and said they don't think it could be breast because at present it was well treated. And then in follow-up, there was nothing. At present also, she doesn't have mass in the breast or axillary nodes. Okay. So they felt it may not be breast primary. So how do you go? So do you agree that this is a carcinoma only? Because that is going to be our first diagnosis, particularly in a known history. It didn't look much as a variant. It didn't look like a lobular carcinoma. And so we have to clear this block on the road. So how do you do? Get more clinical information, which we did, and the answer we got, less likely to be breast primary. Blood investigation, hematology, biochemical, serology, tumor markers. Okay, the common tumor markers were done, CA and CA 15.3, which were negative. Then we said we have to review the slide. That is what you have to do. Like I showed you in melanoma cases, we got the diagnostic clues which were earlier not so clear. And the diagnostic clues were mainly intranuclear cytoplasmic inclusion and cannibalism. So here we wanted to pick up to do so how did we go about? Let me tell you. Now ESG neck showed multiple enlarged metastatic node in supraclavicular region on both sides of the neck and multiple level 3 and 4 nodes. So it's what is it breast primary only, which is presenting with nodes and pleural effusion. Outside such chest CT scan showed mass in the left hemithorax with pleural effusion, with encasement of a large vessel causing SPC syndrome with pericardial effusion. Again, this didn't help us what? Where is the primary? So is it breast, lung, or any other side? Or is it mets from carcinoma unknown primary? The second primary can also be unknown. Again, we said we have to think and dig the history. So this was a pleural fluid cell block. Didn't offer much information and much clue. I have already discussed what type of a. So we went systematically. Is it epithelial malignancy? It doesn't look small cell carcinoma of lung. It doesn't look medullary thyroid carcinoma, small cell type. It doesn't look regular polydifferentiated adenocarcinoma, lobular carcinoma. So we thought it is, let's consider non-epithelial malignancy. Is it polydifferentiated synovial sarcoma or any other sarcoma? No. So what it could be? So it could be malignant round cell tumor. Now what are the common malignant round cell tumor? NHL, ERMS, neuroblastoma, PNET, DSRC2. Out of which PNET and non-Hodgkin lymphoma, particularly lymphoblastic lymphoma, can involve pleural cavity, known to involve, but they are basically monotonous round cells, and this was by no stretch of imagination a monotonous malignancy. I showed you different kinds of cells, size of cell, and plasmacytoid cell. So what is left? DSRCT goes to, in fact, is known to involve ascitic fluid. So also the Burkitt's lymphoma, they involve abdominal cavity. See, in lymphoma also, knowing the type, the age of the patient, generalized lymphadenopathy, which cavity involved, you can sort of a guess what could be the type of lymphoma. So abdominal cavity, think of Burkitt's lymphoma, high-grade B cell lymphoma. Now remember, low-grade lymphoma hardly ever goes to the effusion, hardly ever forms effusion. It is usually high-grade lymphoma. So if you get too much lymphoid population which looks low grade, think about reactive lymphoid population. So reactive lymphoid also is known to occupy the cavities. So disseminated, so this is disseminated second primary, necessary in aggressive malignancy, and likely to be MRCT. So this was our next thought in the mind. Non-epithelium, likely to be disseminated, aggressive MRCT. And now then we decided we should do immunohistochemistry. We have to. Now with this sort of a thing, anybody have any guess what kind of a MRCT? Now here I have just highlighted plasmacytoid cell. That doesn't mean that predominant component was plasmacytoid. Predominant was this small cell. Otherwise, you would never think of small cell, small ground cell tumor in this particular case. Okay. The age was also, I think, 40, 43. So not very young, but we did think of small ground cell tumor. And so primary panel was used, LCA, MIC2, synaptophysin, TAN-CK. Anything else should be added? All these were negative. Okay. So predominant cell population was this. I was highlighting plasmacytoid cells for some purpose. So of course we use desmin. Desmin has to be used in every round cell tumor panel, has to be used, particularly if you are thinking of head neck malignancy. This I always cover in head neck malignancy. Any unusual tumor, please use desmin. And number of cases you will find the desmin is positive. So here also desmin was positive. So naturally we did myogenin, and you can see myogenin is nicely positive and it is nuclear positivity. So it was clear that this was ERMS. From where this ERMS came and how did it go to pleural fluid or pleural cavities? So this was the biopsy. This was all happened outside. Now again, every tertiary cancer center will face the same problems, that patients came terminally with lot of disease in their body or with number of operations done before, and every time you have to really dig the history, particularly pathologists. Quite often history is available with clinicians, that is surgeons or otherwise medical oncologists, but that is not provided. So this was the case of ERMS. This is what biopsy, punch biopsy. Can you tell me what could be the site? ERMS. This was from the nasal cavity. So this is the case of metastatic sarcoma, which came as a second primary after CA breast, which was treated outside. Then patient had pleural effusion, and then he was referred to Tata Hospital. So the puzzle had to be solved, after a long duration. Consistent with non-primary in the notes, operated outside 3 years ago, completed chemotherapy, now presented with recurrence and lung metastasis with pleural effusion. So usually when these are widely disseminated, along with pleural effusion, they also have some other mass. And in this case, it was lung metastasis as well as node metastasis. So also with that seminema case I showed you, there was all retroperitoneal and mediastinal nodes involvement also. So they never is the isolated primary when you get non-epithelial malignancy. So what was the echo message for case 5? Heterogeneous cell population in fluid in post-chemotherapy. If you know, then think about therapeutic histologic maturation. I was harping all the time on the plasmacytoid cells and the abundant dense cytoplasm. I did try to look for cross striation, but they were not seen because this was post-chemotherapeutic. So do not put in slot of consistent with non-primary when primary is known if the morphology is not matching. This is the important. Do not, try to put into the same slot. Despite the rarity of this presentation, it is important to determine the etiology of pleural effusion in every case of non-primary carcinoma. So thoda sa hatke dekha. So think over, make a cell block, use immunohistochemistry, and you can, unfold or the puzzle can be solved. It may deprive, because if you do not diagnose the second primary, it may deprive the patient of effective chemotherapy, which can be given in case of a germ cell tumor, whether it is seminomatous or non-seminomatous, some of the malignant round cell tumors, particularly embryonal rhabdomyocyte. So, and must note that MRCT can present up to 40, 45 years old. So it is not necessarily a tumor of children or young adults, though common presentation is going to be it can be extended. So also seminoma can be extended to 40-year-old. So just don't exclude some of these tumors, round cell tumors as well as the germ cell tumors. So this is the last case. All the four were of one kind because I was told that I can take a lot of time. I quickly cover this case for the special purpose. This was also a young male, breathlessness and weight loss. CT showed various mass, pleural thickening, left axillary and retroperitoneal lymph nodes with pericardial effusion. So, you get some inclination with this particular history. Can anybody volunteer? This is going to be with the mixed cell population. See, the smear was like this. So I have put like this, ghost cells like the pale nuclei and somewhere little, viable cells which look lymphoid. Do you agree? The lymphoid cells dissociated, but they were admixed with polymorphs. And they were not very cellular, not very closely situated. Now, in this particular smear, there are many more polymorphs as compared to lymphoid cells. But the lymphoid cells do look atypical. So now there is a dilemma. Is it just a reactive lymphoid cell and it is an inflammatory, or is it a really metastatic or involvement of the lymphoma? Still better smear. You can really appreciate the atypical lymphoid cell here. Can you decide what is this? This may be a normal mature lymphocyte, so you can compare. Okay, and in between there are polymorphs also, as you can see here. So actually the primary report here went as inflammatory because of the presence of, now GIMSA is very clear. Whenever you see any lymphoid cells or any inflammatory cell, please insist on GIMSA smear, okay, because that gives you the better details. Okay, so this is an atypical, but in spite of, and let me tell you, when you are showing, you are, highlighting those atypical cells, but in a sea of cells, it is your observation. You have to find out the atypical cell. So though I thought these were quite a atypical lymphoid cell, the diagnosis in this case went as mixed inflammatory cell negative for malignancy. This was essentially from cytology department without taking into consideration any clinical findings. And that's why I wanted to keep this case. These things used to happen quite often 30 years down the line. It is not so much common nowadays. So lesson here is atypical lymphoid cell, whether it is in mixed inflammatory background or not, you have to raise the caution. You have to see the clinical and radiology correlation, particularly for mediastinal mass. If the patient is young, and always see the GIMSA for lymphoid cells. And then if you still have a doubt whether they are atypical or they are reactive, you can carry it out through cytometric examination also, but it is usually not required. And in this case, false negative diagnosis was mixed inflammatory was given, but the obvious diagnosis is, of course, lymphoblastic lymphoma, which is a very common situation. Young patient, mediastinal mass, sometimes presenting with SBC. This is usually an emergency because they have to be treated urgently. When you are asked to see the pleural fluid, first rule out lymphoblastic lymphoma. First find out whether there is mediastinal mass or not, whether it is mixed inflammatory or not, suggests at least that this is likely to be lymphoblastic lymphoma. In this case, later on axillary lymph node was done. The cytology was reviewed because clinician was very confident that this is a case of lymphoma. Only thing it was not put on this, and the cytologist did not correlate with clinician and radiology. And that's why I wanted to put this case. But all of you, I'm sure, must have seen similar cases, but they are not missed in today's scenario. So we have finished with the main challenging cases. I just want to summarize. In these first three cases, the histology was matching with cytomorphology. Ovarian primary, this was rare occult primary with presentation in pleural fluid without ascitic fluid. Melanoma of grade 2, there was a history of excision. It was a forgotten primary. Even the patient forgot to give the history. The clinician also did not find. And that's the importance of, in a rare case, you have to examine full body. We used to be taught in the surgery that, entire body skin has to be examined from head to toe. It is just otherwise the melanoma can be missed, particularly if it is on the sole and nobody would see the scar of the sole. And remember, it is usually the cutaneous melanoma which go to the serous cavities. Testicular seminoma, again, which was no primary, disseminated primary, but the history was hidden. and the presentation was unusual. Sometimes clinicians don't give history because they are not particularly thinking that it is the seminoma which is there. In their mind, they want us to rule out any other primary. So that may be the reason. They don't want to make us biased. That is what they tell you when you discuss with them. So that angle has to be also remembered. Always get the patient chart and you yourself go through. We have spent a lot of time in going through the charts of the patient in order to get the history. So the other two cases were, there was a known primary, okay? In this case, papillary thyroid carcinoma. In this case, it was a carcinoma of breast, but the morphology did not match with the primary histopathology. So you have to think, in case of a PTC, it was a transformation in a long-standing primary. In this case, duration was also short, but otherwise the typical history that you will get, because after this I had studied some cases, we got 5 cases like that, the duration was variable, usually a longer duration after the surgery for papillary thyroid carcinoma. ERMS was really very unusual and challenging case, and you don't get it often, but you still can get breast carcinoma. I have seen breast carcinoma followed by lymphoma, breast carcinoma and CML. So it is not very unusual because breast carcinoma are very common and it can be treated and the patient can live long. They can get the second primary. So all these details also you should know. Which cases can get a second primary? You are less likely to get second primary in malignant round cell tumor. So in this case, the post-CT showed maturation and that gave rise to lot of plasmacytoid cells. Plasmacytoid cells were nothing but rhabdomyoblasts. Usually in rhabdomyoblasts, you see cross-striation, but in this case, cross-striation were not here. It was a effusion, pleural effusion. So this is how there was a different kind of a spectrum in each case and different kind of a primary. All were not occult, either forgotten or hidden from this or transformation in primary or second primary. And the last case I kept just to tell you how to avoid the false negative, diagnosis in pleural fluid. And particularly in that typical scenario of T lymphoblastic lymphoma in young or adolescent patient, where a clinician tells you his primary diagnosis. So pleural cytology is a crucial role in staging the malignancy and it always thought with mix. Don't consider it is so clear that always you have a primary and histology matching, so you can in one line say consistent with metastasis. So you have to be familiar with mimics and pitfalls, which helps in avoiding the false positive as well as false negative diagnosis also. Awareness of different kind of presentation, different primaries, the clinical radiological findings and subtle diagnostic clues, which I try to give in every case, improves accuracy and helps pathologists or cytologists to crack the nut of primary, as was exemplified in our cases. Now, in serous carcinoma also, all of you know, the diagnostic clues are, of course, tight clusters, papillary clusters, vacuolated cytoplasm, pleomorphism, and stromoma body, but polyploidal cells and presence of mitosis also helps. Some malignancy masquerade as carcinoma, but are not, and yet they are chemosensitive. For example, germ cell tumor, which is the best example. Though rare, the distinction from carcinoma is absolutely necessary because it is still treatable even if it goes to pleural fluid. Cytology with the cell blocks has the strength to offer the final diagnosis with help of immunohistochemistry. You can also do, by the way, molecular studies on the cell blocks. Okay, particularly in case of unknown primary malignancy and second primary, because unless the clinician knows what is the kind of a primary, even in unknown primary, he cannot treat as happened in the first case. So cell block should not only be used for immuno, but also for molecular testing, which facilitates not only the diagnosis, but targeted therapy in advanced cases. That is called theranostics. And the best example is adenocarcinoma of lung. In this case, we do ALK1 testing on pleural fluid cell blocks. We have been doing in that hospital, and it is done at various other centers also for the proper treatment or for the targeted therapy. So with that, I end my talk and thank you very much for listening patiently. And I hope I have given you a different kind of a spectrum and different kind of a cells. Some of them were rare cases, but you have to diagnose however rare it is, and you have to crack because you are going to tell clinician how that patient should be treated further. So actually, this is the last case So I just wanted to tell you that there are various preparation methods for cell block. Please get into it. Please try to make a cell block in pleural fluid, which is of a great help. When the material is adequate, you can straightway make a smear with sedimentation. You can use the blood clot in the formalin for the cytology for the cell block. But when the residual sediment is very scanty, you can use agar embedding or the thromboplastin plus stool plasma method. In fact, we have a cytology manual and all these methods are given. I hope most of you are aware of it. Tata Hospital had produced a cytopreparatory technique manual and everything is given there. So what are the causes for suspicious? When you cannot give the definitive diagnosis of suspicious for malignancy, of course, when the concentration of abnormal cells is low, sometimes there are many reactive mesothelial cells and they interfere because these mesothelial cells are admixed with the malignant cell. And it is difficult to know which one is actually mesothelial and which one is malignant. When the lack of ancillary testing, cell block is not made and immunohistochemistry cannot be done. Or sometimes cell block is made, but the cellularity is scant. So you have to learn the technique of making a good cell block also. And very rarely you have a good cellularity, you have made the cell block, and cellularity in the cell block is also good, but the immunostains are inconclusive. That may contribute to giving a diagnosis of suspicious or atypical. So see that your lab develops a good technique for making smear, for making cell block, for making and doing immunohistochemistry so that in every case of pleural fluid, wherever you get abnormal cells, you can reach the proper diagnosis. So once again, thank you very much for patient listening. And I hope this is of use to you. And if anybody wants to ask question, please feel free for the same.
Thank you very much, madam. Your cases were really excellent and you were very, very informative and you explained it very